Health officials have told the White House that the virus is even easier to catch than originally believed. A panel at the National Academy of Sciences says it appears that people can spread it by talking or even just breathing, not by through coughs or sneezes. We're also getting jarring indications of the incredible financial toll COVID-19 is inflicting. This week, more than 6 million people filed for unemployment claims for the first time. You add that to last week's total, we're now seeing 10 million Americans losing their jobs in a span of 14 days. We're going to talk more about that, as I said, later in the program. But now let's get to the latest coronavirus numbers. The United States now has more than 230,000 cases and nearly 6,000 deaths. To give you some context, at the beginning of March, just 1 month ago, we had only 70 cases and only a single person had died. New York, it is the hardest hit state by far. Since yesterday, more than 400 New Yorkers have died from the virus, and the state is approaching 100,000 confirmed cases. It's believed will be there before the end of this evening. New Jersey, a distant second, with 25,000 cases and more than 500 deaths. But as you can see from this heat map, every state is being impacted now, and big cities just about everywhere are feeling it the most. And now, mayors of the two largest cities in America, New York and Los Angeles, telling residents to wear masks if they leave the house. Globally, we just passed 1 million cases worldwide, and more than 50,000 people have died. Roughly 60% of global deaths have occurred in Italy, Spain, France, and Britain. As the numbers continue to spike here in the U.S., hospitals in scores of cities are already complaining and are vocally being concerned about the dwindling supply of essential protective gear like those surgical masks. Take a listen to these nurses on the front lines in California and New York.
I'm in the room taking care of a patient who is COVID positive. I'm wearing that one mask, and then if I have to go into another room to take care of a patient who is a potentially rule out for COVID-19, then I'm exposing that patient.
We have to reuse them for one each day. And the next day, and the next day, and the next day until it goes bad.
It's like we're going into a war with no protection. We know how this is transmitted. We know that this is incredibly contagious, and we're seeing it. We're being exposed over and over again, and it is criminal. This is absolutely criminal.
You add to those acute concerns that it appears that help is not on the way, at least not from D.C., at least not to the degree that is desperately needed. The Department of Homeland Security now confirming that the national stockpile of protective gear is nearly depleted. The situation not much better as respect to ventilators. President Trump has said the government has tens of thousands of them ready to be shipped out. He did omit, though, that at least a quarter of them reportedly do not work. New York Times reporting that a maintenance contract lapsed, so thousands of them broke due to neglect. Governor Cuomo says New York will exhaust its ventilator supply next week, and he is not expecting the cavalry to come.
I don't think the federal government is in a position to provide ventilators to the extent the nation may need them. Our attitude here is, we're on our own. I will ask the federal government if we get to that point. Just assume you are on your own in life, right? And that's the operating assumption.
To put a finer point on that, Mayor de Blasio says New York City alone will need 400 by Sunday. Just today, President Trump invoking the Defense Production Act, which will allow the government to order companies like GE and other corporations to make ventilators. He's been under pressure for several days, if not even well over a month to do that, but just now he is invoking that authority. This growing health crisis, it is forcing doctors to make life and death decisions that were thought imaginable just a few weeks ago. Instead of families deciding whether or not a patient should be resuscitated, hospitals in New York City are now reportedly implementing DNRs, do not resuscitate orders. Plus, EMTs in the city being told that people in cardiac arrest who can't be revived in the field should not be brought to hospitals. The hospital's just too strained to deal with those situations, and consequently the morgues filling up. The city has dispatched 45 new refrigerated trucks, as many hospitals have no place to keep the bodies. Plus, FEMA is asking the Pentagon for 100,000 body bags so it can send them to places that most desperately need them. I want to bring in our guest, Dr. Felipe Serrano. He's an emergency room medical physician. He's associated with Mount Sinai Hospital in New York. Doctor, thank you so much. And I want to remind everyone, we're talking about New York now, but as Governor Cuomo has said in these nationally televised press conferences, New York is the future. So if you're watching me in California, if you're watching me in Texas, if you're watching me in Virginia, Maryland, Massachusetts, Eastern Seaboard, the reason I laid out all those numbers was not to scare or to inflame, but to put an accurate set of facts as to where we are right now, our present, our near future, and we're going to also talk a little bit later about our longer future, because the Governor Cuomo today said he's expecting to be dealing with this crisis, that it could go into June, July as well. So if anybody believes this is an acute window we have to just get through in the next 2 weeks, I hope you're right, but the data does not say so. So doctor, you heard all of those. First of all, is there anything that I reported that surprised you? From you have the ground truth, you have the view that the rest of us don't. You see what's going on in the ERs. Does that reflect your reality?
Thanks, Richard, for having me. And it really does. You know, the numbers keep going up, and we keep seeing more and more patients. And the tricky thing about it is that a lot of these patients that we're seeing are being admitted to the hospital, right? So the ones that get to go home, we're often not seeing in the emergency room because they're being seen by telehealth providers, or they're actually just heeding the calls to not come in. So the ones that we're seeing in the hospital are ones that are staying in the hospital or need to be intubated or need to be in the ICU for a prolonged period of time. And so we're really filling up our wards. I know that a lot of pediatric hospitals in the city have converted to take care of adults. We've converted a lot of our operating rooms into ICUs. Different services are stepping up to staff the ICUs or staff the floors, but we're quickly filling up the available space that we have in the city and honestly the state to take care of these patients. And unfortunately, they stay in the hospital for a prolonged period of time. So even if the number of new infections starts to go down, or if we peak as we think about maybe in a couple of weeks, those people who are already admitted to the hospital are going to be there, and we're just going to have no space for those people to come in.
I saw some visuals from Mount Sinai, and it's hardly just isolated to Mount Sinai. We talked with Elmhurst and so many other hospitals right in the teeth of this. There doesn't seem to be, wherever you turn, there is people on gurneys, people attached to ventilators. Is there almost, seemingly when you're in there for your 9-10 hour shifts, from the minute you walk in to the minute you leave, it's just rinse and repeat. You're seeing wherever you turn an unending supply of people in need.
It really is, and that's the tricky, or the toughest part is that we're seeing basically almost 70 or 80% of our volume is coronavirus patients, right? We're still seeing a little bit of other things, right? We still have to take care of patients who have heart attacks or strokes or somebody who has appendicitis, because those things still are happening. Coronavirus doesn't stop that, but what's scary is the vast majority of patients are the coronavirus
and
patients.
If I could, doctor, somebody with an appendicitis or somebody dealing with trauma, those off-site locations, for example, the naval ship that came in and what we've seen at Javits, et cetera, is that the idea that they will be able to handle a lot of the cases that aren't COVID-19?
The hope is they'll be able to admit some of the patients. I don't think they have operating rooms. They might. I may not be correct on that. But the process right now for getting the patients to that hospital, or what's supposedly starting at the tennis grounds for the U.S. Open, is that they have to be coronavirus negative, right? So if I get a patient who's coming in with an appendicitis or whatever it is, and I have to admit them to the hospital, I can't just send them directly to the ship or directly to the tennis grounds until the test result comes back as being negative. And I don't know if you've seen, a lot of the tests that we have are taking, 12, 24 hours, and so it's not a decision that we can make on the spot immediately.
To that end, doctor, the two things we hear and doctors have confirmed is the concern about not the will of the medical community. It's unbelievable to me the heroism you see of the folks on the front lines, not just the doctors, the RNs as well, everybody that's part of this, and people coming out of retirement to help out. My gosh, right? But it's that they feel they're going into a fight without the armor that they need. Talk to that. Talk about the concerns, the rationing, if necessary, right now, for those masks, for that the face masks, for the protective gear, obviously for the tools to fight this. I mean, we're early on in this process, and already it's palpable by some that are saying, you know, I take the risks onto myself here. I understand it comes with the job, but I didn't think we were at this position this early.
You know, it's hard to say because the information changes all the time, right? As you just reported, the news that just came out about coronavirus being possibly transmitted by breathing or talking, that was news to me today as well, right? Sort of the common sense or the common understanding among medical providers was that it was through sneezing or coughing or through droplets, as we call it. Anytime you sort of eject droplets from your nose or mouth, and they land on a surface or they land on another person, that's how the disease is transmitted. Now we're talking about possibly being transmitted by breathing or talking, so it kind of is a question of what kind of protection we need, right? The recommendations from the CDC and the World Health Organization is an N95 mask with a face shield and a gown. And right now, thankfully, at my hospital, we do have enough of those for the providers, both nurses and techs and physicians, to have. Right now what we're doing is we get an N95 for the day, which is the mask that we wear, and we keep that throughout the day, which is reasonable given that basically all of our patients are coronavirus positive. And then we have a face shield as well, and we switch out the gowns between the patients. The concern is that even though we might have enough now, after Herculean efforts from Governor Cuomo and our hospital administration, is if this continues, we're going to eventually run out. And as you said, the rest of the country won't have enough, right? Mm-hmm. Right now, the focus has been on stocking up New York City or New York State and New Jersey, as we are the ones suffering the most. But if we end up using all that personal protective equipment, who's going to be able to send some to Texas or Louisiana or California whenever their cases start to spike?
Talk about some of the decisions. You and tomorrow I'm going to be joined by representatives of the EMS service. And as I understand it right now, there is directive that if you can't get a pulse when the bus goes out there to try to, don't bring them back to the hospital because you guys are already overloaded. Moreover, you guys are having to make triage decisions right now. Talk about the decisions, because it seems almost that it's wartime medicine in a real way, where you have to make a decision who best has a chance to make it. And if we're here on April 2nd, where could we be in April 21st or 22nd? Give a preview to, you guys have to be talking about this out loud. I know they're doing it in other hospitals and even other states right now. How do these understandable, though difficult decisions get made? Who makes them?
It is really hard, right? And that report that we're not going to continue resuscitation efforts after 20 minutes has been under discussion, for the past few days. As we realize that as these numbers get higher, we have a limited number of resources, a limited number of manpower, and we have to focus those resources on trying to apply them as effectively as possible, right? And unfortunately, somebody who has been down for 20 minutes without a pulse, their chance of recovery is slim to none, right? And so before coronavirus, right, we would give everyone a chance. But whenever we have a limited number of resources, we have to make that decision that, if the chance of you coming back with a normal neurological outcome is very, very low, then the risk of exposing both the emergency medical providers sort of on the field, plus the physicians, plus nursing, plus everyone who's involved in the care of this patient is higher than the chance of bringing that patient back. And so it's a very tough decision to make, right? Because in our career, we try to help everyone in whatever way we can, but it is a practical one right now. As to who's making these decisions, I'm honestly not sure. I'm sure that the Department of Health is bringing this down.
But doctors said to me that each case is unique and that it can't be a bureaucratic decision. Doctors, and there's so much weight on the shoulders, but they know better than anyone what they're looking at in real time. And maybe there's some consultation, but at the end, the doctors are the right people to make the prioritizations and the decisions as to resources, time, and effort. Is that too much to be putting on the shoulders of a doctor?
I think that as physicians, and like you said, individual cases can vary widely, right? And sometimes people will say that cookie cutter medicine is not the right way to do it. But I tend to think that in situations like this, where we're dealing with huge numbers of patients and trying to contain one disease, cookie cutter medicine and cookie cutter decisions might be the best thing to do. If we have individual physicians trying to practice their own version of medicine in this situation, we're going to have a wide variety of practices that we can't coalesce into one system. And I think we're going to run into problems if that's the case. So I appreciate that some of these decisions are being made on a systems, sort of in the system form, as opposed to making me make that decision at the bedside.
We have a lot more questions for you, Doctor, and thank you so much. Dr. Serrano joining us. When we come back from the break, we'll continue our conversation discussing the challenges that is modern day medicine right now as we deal with this pandemic, both in the hospitals and also when these doctors finish their shifts and go home. Stay with us.
The influx, not just into the hospital, but into our ICUs, is beyond anything that we've seen before. We're doing our best, but it feels like wartime.